I'm here this afternoon with Professor Sir Michael Rawlins, who is Chair of the Medicines and Healthcare Products Regulatory Agency, and we're here to talk about your life and career.
Well, it's very nice to be with you and talk to you as an old friend.
Thank you. And I should first of all congratulate you on your new knighthood, which is, makes this very timely.
Well, thank you very much. It's a lovely thing to have happened, and I join a bevy of three other very distinguished physicians who are also what they call Knights Grand Cross of the Most Excellent Order of the British Empire.
Well, congratulations again.
Thank you.
So we might perhaps start at the beginning with your childhood influences and reasons that you wanted to pursue a career in medicine and science.
Yes. Well, I liked natural history when I was a kid. I liked bird watching. I wasn't very good at it. I collected butterflies and things like that. And then when it came to doing things like GCSE and so on, I wanted to do biology as well as physics and chemistry. And in the 1950s, the only thing you could do with biology was medicine. And I can't claim at that stage to have been terribly determined to cure all the ills of society. It was just sort of a natural progression from biology A-level, and that at the time was all I could think of doing with my biology, do medicine. So I applied to Cambridge to do medicine, and they turned me down. I thought my grandfather having been there, it might have helped, but nepotism didn't count in 1959. So I applied to Thomas's, where my mother had been a nurse, where nepotism did still count. And when they said, "Why were you applying to Thomas's?" I said, "Because my mother was a nurse here." That was it. I was a shoo-in.
And no influences, no family medical connections of major sorts?
Yes. My own father died when I was very young, when I was about 5. 10 years later, my mother remarried. And she married a GP, who was a lovely man, absolutely lovely. I couldn't have had a more wonderful stepfather. So he in a way, didn't encourage me, but he was very supportive. And he used to remind me sometimes, I used to talk about, some interesting bit of pathology or something like that. And he used to remind me, but what about the person behind it? And he drew me out to think about more of the sort of sociological aspects to medicine, as apart from the hard science. He was a lovely man, and I can't give him more thanks than I have.
And so you arrived at Thomas's. Was it clear to you what you wanted to do fairly soon after you arrived? Or did that take time?
Well, the first thing I wanted to do was to make up for not getting a Cambridge degree. So I did an intercalated BSc. And in those days, you could either do physiology or you could do anatomy. And I quickly discovered that the anatomist usually got first and the physiologist usually got 2 1s. And so I did anatomy. And I loved it. It did comparative anatomy, neuroanatomy. And I really loved it. And my interest in science and research really stems from that. It sounds strange, but that's... And we even got taught some statistics. And I can remember one of the anatomists explaining regression. And although I didn't really understand it, I'm not sure I still understand the entire mathematics behind it, I understood the principles of regression analysis. And so that stuck with me. And so I really enjoyed that. And then I went on to do the clinical course. The first 2 years I was terribly occupied with music. I used to conduct the orchestra. We put on operas. And after 2 years, I hadn't done a lot of work. And I realised I'd going to have to get a move on. And so what I did was, I thought if I could understand pathology, I could understand medicine. And so for the last year almost, every morning I went down to the post-mortem room and watched while they did a post-mortem. We did post-mortems. I was the only student there. The pathologists loved having me there, and they were teaching me pathology all the way through. And it stood me in wonderful stead, because once you've seen acute myocardial infarction or something like that, then the clinical bits come actually quite simple and straightforward. So I did well in pathology. I got a distinction in finals in pathology. And I also got distinctions in pharmacology or clinical pharmacology for some reason or other.
Right. Well, that's good, isn't it?
It was good. It was a good start, yes. So I did my house jobs at Thomas's, or the pre-registration job in medicine. I was terribly disappointed, though, not to be given the professorial job, because at that stage I wanted to have a career in clinical research. And the obvious thing to start off with was to become the professorial houseman. And the reason why I wasn't accepted was only emerged for 10 years later. It was quite a compliment. One of the physicians I'd worked for and got to know was a man called John Harmon, Harriet Harmon's father. And he, when it came to the choosing the houseman, because he was the senior physician, he got first choice, and he usually gave the first choice to the professor of medicine. On this occasion, he decided he's going to exercise his right to have first choice, so I became his houseman. It was years later that I discovered this. So I was his houseman. I went down to Portsmouth to do surgery. I went back to Thomas's as a third job to do neurology. And then I went to the Brompton to do chest medicine. And at that stage, I sort of didn't know what specialty I wanted to do. An organ specialty didn't seem to be that much fun. Chest medicine was all about asthma and chronic bronchitis. And neurology was all about headaches and so on and so forth. Anyway, I got the membership, and then I wanted to do academic medicine. And so I went to see Bill Cranston, who was professor of medicine, and said, how do I get into academic medicine? He said, well, a bit of luck. He said, one of my lecturers is taking a year's leave of absence. Will you do his locum? And that was it. I was a locum for a guy called Clive Rosendorff for a year. And then towards the end of the year, he actually resigned and went back to South Africa, where he'd come from. And so I got the substantive job. So and I did clinical research and clinical medicine at the same time. And the research that Bill Cranston made me do was to look into temperature regulation, which he had a specific interest in, and the mechanism of action of aspirin. Mm-hmm. And that was my career, as it were, made for me. Mm-hmm. Pharmacology and general medicine. I worked with Gordon Duff. He was a PhD student, and we started off doing rotten things to each other, giving ourselves fever and giving aspirin to bring it down. And so that was my introduction to clinical pharmacology. After 3 years there, I decided I wanted to get trained further in clinical pharmacology. At that stage, the place to go was the Hammersmith. I applied for a senior registrar's job at Hammersmith and got it.
That was with Colin,
That was Colin Dollery. Yes. And Alistair Breckenridge was a senior lecturer there. Donald Davis was there. And amongst the sort of registrars and senior registrars and lecturers and so on, there was Charles George, now Sir Charles George, Michael Orb, who eventually became Dean at Liverpool University, Dean of Medicine. And so I started learning more about clinical pharmacology, as it were, from clinical pharmacologists rather than just doing pharmacology. And it was about that time that I also became interested in the work of Volker Sjökvist in the Karolinska Institute in Stockholm. I was particularly interested in the way he was starting to explain inter-individual variation in response to drugs. I had noticed when I was doing neurology that when I prescribed phenytoin, some people got a good response, some people got toxic, and some people got nothing at all. I didn't understand what it was all about. And it was he that demonstrated that the individual differences in the rates of drug metabolism of phenytoin correlated obviously with the blood levels, and correlated to a large extent with the therapeutic response. Mm-hmm. And I was sort of fascinated by that. So I applied for an MRC, Medical Research Council, travelling fellowship, and to spend a year with Volker Sjökvist at Karolinska. It was at the Huddinge Hospital. And I learned a lot about some of the techniques. And I also did some research looking at particularly the effects of beta blockers and looking at blood levels in relationship to beta blockers and so on. So, wonderful time.
You initiated work with Gordon Duff when you were at St Thomas's that made the rest of his career, I guess.
Well, I don't think it made his career, but
very interesting inflammatory mechanisms that became elucidated
yes, he did.
latterly.
Yes.
And you spent a bit of time with Colin, but
yes.
you didn't. Did you go back to Colin afterwards? I don't think that.
That was while I was in Sweden. There was a job advertised in Newcastle, a new chair of clinical pharmacology. I was still a senior registrar. And for some reason or other, I applied for it. For some reason or other, I got it. So I went straight from being a senior registrar to being a professor.
And that was at an extremely young age.
I was 32.
32.
And I spent 33 years in Newcastle as professor of clinical pharmacology and as a physician in the hospitals. So I did combined general medicine with clinical pharmacology. And one of the things I learnt was, if you first don't succeed, try and try and try again. Not long after I got to Newcastle, I wanted to set up an overdose unit. I was very envious of what you had in Edinburgh. My colleagues in medicine were very opposed to the idea, very opposed to it. But eventually they agreed. And now, they'd be embarrassed to hear that somebody had ever opposed the idea, I think.
You trained a number of people, I think, in Newcastle?
Yes. When I arrived in Newcastle, John Walton had managed to get some money from the Wolfson Foundation to build a building for me. So basically, upstairs was laboratories, downstairs was offices and a clinical investigation suite, which Newcastle never had in those days at all. So I could do volunteer studies or patient studies. We didn't do overnight stays, it was just daytime studies. And also did outpatients there as well, which meant that the hospital would pay for the nurses. It was a very good wheeze, wasn't it? So and then I had some really good young people came to join me. Phil Routledge, who ended up in Cardiff as Professor of Clinical Pharmacology, Robin Furner, who ended up in Birmingham, and then Peter Blaine joined me.
Yes.
He's frightfully important in the Ministry of Defence. And of course there was Nick Bateman, and of course Simon Thomas, who's still there and very active. And it was really Nick and Simon who really set up the overdose unit. I mean, I gave political backing, but they did the day-to-day heavy lifting. And then in the late 1970s, for some reason or other, I was asked to join what was then the Toxicity and Clinical Trials Subcommittee of the Committee on Safety of Medicines. David Graham Smith from Oxford chaired the TCT, as it was called. Mm-hmm. So I spent a year with him on that. And then in the beginning of 1980, there were some retractions in government, as always are. They decided to merge toxicity and clinical trials with adverse reactions. And would I go on the main committee? So I joined the main committee, which was being those days chaired by Sir Eric Scowen, former Professor of Medicine at St Bart's. And I learnt both from him and from John Walton how to chair meetings. You've got to know the papers, you've really got to be on top of it. And by and large, you want to know what you want to get out of it. And so I stayed on the CSM, and then after a few years, as I said, they merged adverse reactions and efficacy, and they set up this new subcommittee called SEER, Safety, Efficacy and Adverse Reactions. It could have had another acronym. It could have been Adverse Reactions, Safety and Efficacy, but
yes,
but it wasn't. And Alistair Breckenridge, who by then was on the main committee too, and I were very worried about adverse reactions because we thought they'd get lost off. And so they decided to set up an adverse reaction group of SEER, Argos. And basically it was me and Alistair and the Secretariat. We became known as the Argonauts. We met every month and we used to go through the drug analysis prints, the yellow card reports, to see whether there were any signals. And we were aided and abetted by two lovely people. One was a woman called Sue Wood, who died many years ago, very sadly. And the other is June Rain, who is still working for the MHRA, and now running adverse reactions for Europe. So, because she chairs the Adverse Reaction Committee of the European Medicines Agency. And so we used to look at these adverse reaction reports and decide how many reports constituted a signal that would require further investigation. And we just sort of invented an arbitrary rule, 3. And it wasn't until Stephen Evans, who's a statistician, devised a far more sensible approach, what he calls the proportional reporting ratio. So you look at the number of reports of the skin rash, say, in relationship to the total number of reports on the database.
Yeah.
And from that, you can look to see whether your drug, which has got, 6 and only 10 people have ever taken it, whereas on the whole database there were 100, but 10,000. You can do a proportional rates ratio, and you can even get a p-value if you really try hard enough. And so I stayed on the committee. I became vice chairman in 1998 when Bill Asher was chairman. And then in 1972, I became chairman, and Alistair became vice chairman. And then I did 2 terms, and in 1998, my term of office was coming to an end. I hadn't a clue what I was going to do with my...
It's jolly lucky something came along, wasn't it?
And something came along, yes. I think it was September 1998. I was chairing a meeting of the CSM, and the secretary handed me a note. He was always handing me notes, and I sort of stuffed it in my pocket and forgot about it. And when I went back to my office, the secretary came in and said, "Have you called that number?" And I said, "Oh, what number?" "The one on the piece of paper." "No, I think you should." He'd recognise the number. So I called the number. It turned out I was the Secretary of State's office. And they said, the Secretary of State would like to talk to you. And I said, face-to-face or by telephone? "No, face-to-face." I said, "What's it about?" "No idea." So, got on the train, and on the train was Alan Langland. I said, "I've got this funny call. What's it all about?" And he said, Dunno, he said. "It might be about NICE. Liam will give you a ring over the weekend." This was Liam Donaldson. By then he was Chief Medical Officer. So at the weekend, Liam said, "They're looking for a chairman for this new organisation called NICE. The Secretary of State isn't really allowed to discuss it with you, if you are, but he wants so he's going to start the discussion by, you're a retiring chairman of the CSM, have you any advice to give? And when you finish that discussion, it might happen to government NICE." You see, so I didn't know much about NICE, and so I managed to find out a first-class service over the weekend and read it assiduously. And on the Tuesday, I drove down from Newcastle to Brighton and met Frank at, I think it was the Imperial Hotel. And as we were walking down the corridor for lunch, he said to me, "Now, I understand we're supposed to be meeting to discuss your leaving the CSM, and have you got any advice for me?" And I said, "No, you've chosen my successor. He's a great guy." "None at all." And he said to me, "Good, we'll now talk about NICE. You'll have to apply, you'll have to be interviewed, but you'll do." This is typical Frank Dobson. It's always like this. And then he said, and for this I always admire him, he said, "You're not my first choice. I really wanted Naren Patel." I think then Sir Naren, now Lord Patel, very distinguished member of the House of Lords. But Naren said his wife wouldn't like him to spend so much time down in London. I offered to speak to his wife, but no. And then years later, when I got to know Naren, I asked him about all this, and he roared and laughed and said, "Yes, he did want me to do it, but," he said, "I'd already agreed to do this NHS Quality Improvement Scotland.
Yes.
It hadn't been announced, so I didn't like to explain to Frank why I couldn't do it. So I do what blokes do. I blamed the wife. And then when he wanted to speak to my wife, I wanted her to appear in front of me." So I was interviewed. That evening I got a phone call to say that I'd been appointed.
Amazing. And so at that time, it was just building blocks at that time, just a plan, or not even a plan. Maybe.
Well, no, there wasn't really. There was a plan laid out in this white paper called a first class service, which expected NICE to do basically 2 things. One was to do technology appraisals looking at the cost effectiveness. And secondly, was to develop clinical guidelines. The cost effectiveness bit was actually quite interesting because in about January or February 98, before NICE had really been thought of, I was summoned one day to meet one of the health ministers, who said to me, "We're thinking of introducing elements of cost effectiveness into the selection of new drugs for the NHS." Because at this time, if you remember, in the 1980s, 1990s, there was a lot of trouble over the availability of beta interferons, where some hospitals would do it and some hospitals on grounds of cost.
A postcode prescribing.
Postcode prescribing, exactly. And so she said, "What we're wondering," she said, "is could your committee, having made a decision on quality, safety, efficacy and licensing decision, then make a second decision about cost effectiveness?" This came completely out of the blue. And the answer I gave is one that I actually still believe is the right answer. I said, no, I wouldn't advise it. Because knowing committee behaviour as I do, If they know in an hour's time they've got a rotten cost-effectiveness decision to make, they'll mess around with the quality, safety, and efficacy. The pharmacist can always find you something that's not quite right. The clinical trials can always show you something's not quite right. They'll fudge the first decision in order not to have to take the second one.
Yeah.
And I actually wrote her a memo afterwards, a little note about, emphasising my views. But I've lost a copy. I'm sure I kept a copy, but I can't find it. I keep on thinking perhaps I'll be brave and do an FOI of the Department of Health.
Well, that would be brave. But the separation is crucial.
Absolutely. It wasn't. Yeah, that's right. And so for the technology appraisals, we set up the programme, and the first chairman of the appraisal committee was David Barnett, a very distinguished clinical pharmacologist, and he was terrific. And he got to grips with it. And I assembled a board of non-executives. Frank Dobson, who was really very good, he allowed me to comment on the statutory instruments that he was going to lay before Parliament, and and there's one or two little changes that I suggested he made, and he did. One of the great things about Frank was, and Alan Milburn was the same, is they just let us get on with it. They didn't interfere. But the very first board meeting, we had to make an important decision. We had to appoint a chief executive. The job was advertised. I interviewed with the chief nursing officer, 6 people, and I thought Andrew Dillon was the right man for the job. Alan Langlands agreed, because he was, and Frank Dobson, on the advice really, I think, of Alan Langlands, agreed to his appointment, because the board had to get the Secretary of State's approval. So the very, very first board meeting, they had never met each other. They had to do this. And I got to know how to handle that sort of situation. You just throw yourself on your mercy. I said, NICE opens tomorrow morning. There's a public ceremony. We've got to have a chief executive. He's waiting outside. He's been approved by... Just say yes. And they did.
So he was a trust chief executive at St
George's, yes. So he had a good track record, and he wanted a new adventure in life. And he's been brilliant. I mean, people very kindly talk about how successful NICE is and my contributions, but Andrew's is even greater. He's a real manager and is a great, great guy.
Do you want to just remind us how the head count and the budget increased over your period?
Oh, yeah. Well, yes. The first budget was about 5.5 million. We took over responsibility for the confidential inquiries, and that brought a bit of money. And we also nominally got money that had been given to the colleges, the Royal Colleges, for clinical improvement research. And we were told that we were to use that budget, that 5 million, for our guidelines, and they gave us an extra 500,000 for the technology appraisals. Mm-hmm. Over the years, it increased to, when I left, it was well over 60 or 70 million. But it was slightly awkward because I had to go around the Royal Colleges to tell them that clinical improvement money they were getting, they were losing. The bad news was they were losing. But, I said, the good news is I'll give it back to you if you do guidelines on the type subjects that I or NICE will specify, and to a methodology that we will specify too. And so we established these guideline collaborating centres at the various little colleges. And they've grown from strength to strength. And NICE doesn't actually do the guideline. It's done, as it were, by the colleges. But it gets buy-in from the professions. Yeah. But NICE makes sure that they're not, breaking the rules, as it were, about how to develop a good guideline. And in many ways, I think what NICE's most successful achievements has been the guidelines. I think
so. That's an interesting statement, because most people know much more about the technology appraisals because of the news media interest it raises. But you don't think that's the most important thing?
No, I don't. And when I left, only about 30% of NICE's budget was spent on technology appraisals. More than twice that was spent on guidelines. And the guidelines have had a real impact on clinical practice. And nowadays every young doctor and some older ones have them on their smartphones, and they're used. And I always had to tell people that the guidelines were guidelines and they weren't tram lines, and they'd got to use guidelines in a way that was sensitive to the particular patient in front of them. But I think it's the thing that NICE has done that I think it's had a huge impact is the guidelines. The technology appraisals have helped, and and then we took on public health when we merged with the Health Development Agency, and the public health community recognised that the value that we brought, and of course we did cost effectiveness with that too.
Yes.
As you might imagine, public health measures are highly cost effective compared to new pharmaceutical agents. Highly cost effective. So NICE has carried on from strength to strength, and it's largely due to the individuals around me. The non-executive directors that we had. The first vice chairman was Tony Cullier, who is a health economist. I knew nothing about health economics, and I knew I needed a really cracking health economist. And so many health economists take a sort of utilitarian view, the greatest good for the greatest harm. Tony's much more sensible than that, and is prepared to finesse things under certain circumstances. He was a huge asset.
So the normal term of office in government posts is usually about 3 years.
Well, yes, and then
sometimes
you get reappointment.
But you didn't do 6 years.
No, I did 14 years.
14 years.
Yes, I kept on being reappointed.
But I mean that is a fantastic monument to your work chairmanship. So what were the high points? What would you say were the things that you're most proud of that time in NICE?
Well, one of the high points was the very, very first technology appraisal we did. Enza for flu. Made by a British firm, Glaxo. And there was good, reasonable evidence that if you inhaled Enza, it reduced the symptoms by 1 day, from 5 days to 4 days, or 6 days to 5 days, or whatever it was, at a phenomenal cost. And so we set up a rapid appraisal process for it, and basically we advised doctors not to use it. We didn't have powers to stop them. Richard Sykes, who was the chairman, was absolutely furious, stormed into Downing Street, told, as it were, the Prime Minister, Tony Blair, to reverse our decision as a minimum and abolish us. Even better still, we'd only been going 6 months. And Blair backed us and said, I have created NICE to make these difficult decisions, and I'm not going to interfere. That's their conclusion, and that's it. And the interesting thing was that people got it. I mean, there was Times editorials, which I've still got copies of, saying, that we'd made the right decision. And doctors also, although they could have prescribed it, I think about only 200 prescriptions were used over the following winter. I think, not just that, but over that 10-year period as NICE grew in stature, doctors changed their minds about their rights to prescribe what they wanted, and become much more reasonable about doing what the health service could afford. I think that's right. I think they understood that much more.
I mean, it is a great British export. Many other countries in Europe are developing similar things or schemes. Yeah. The Americans don't have it, and you've written in the New England Journal of Medicine about NICE and what it achieves. Yeah. So they obviously recognise its value, even if it's a difficult idea for the US.
Yeah.
So that was NICE.
So that was NICE.
And you had to move on again, and you sort of came a full circle.
Well, yes, because Gordon Duff, who'd been appointed to chair the MHRA after Alistair had done his stint, decided to move to Oxford and couldn't do the MHRA as well. And he rang me up, actually, and said, I'm resigning, why don't you apply? I had to be interviewed. Dame Sally Davis and one or two others interviewed me, and I was offered the job. And as you say, it's like coming back home in a way, because I'd spent nearly 20 years in and out of the MHRA and its predecessor, the Medicines Control Agency.
Did it feel a bit like déjà vu? Were some of the same discussions still happening? Or?
No.
So
It's moved on. When I first joined, our main aim was to try and keep new drugs off the market, because they were going to cause us a headache. We were licensing new anti-inflammatory drugs like binoxyprofen or Oprin. We were always having troubles with oral contraceptives. All of that's gone. And the MHRA is encouraging the pharmaceutical industry to develop new innovative products.
Yeah.
And everybody's extraordinarily complimentary about the MHRA.
It does seem to want to work with industry to do the right thing.
And the idea of scientific advice, it was once suggested when I was a member, we ought to give scientific advice. Oh, no, we couldn't possibly do that. No. And I said, but the FDA do it, why can't we do it? No. But we've got around all that, and it gives scientific advice, it has the innovation office, and it's an extraordinarily successful venture.
And I guess another thing that's changed is the use of biologicals, which really weren't around the last time around.
No, that's right.
Now make up the majority.
Yes. And of course, now we have biosimilars to, when I say worry about, it's not quite the right word, but they're an important component of the portfolio that we look at. And as you know, the National Institute for Biological Standards and Control joined with the MHRA a few years ago, and have become a very critical component of what we do, particularly in relationship to biologicals. Mm-hmm. And then, of course, the third component, which was sort of coming in when I left the regulatory scene, is what's now the CPRD, the Clinical Practice Research Data Link.
So the big data approach.
Big data approach. And that's been extraordinarily successful too.
Mm. Yeah, I don't know whether you have views about how one should manage that. But clearly the public's been a bit reticent about their data being shared, but that could be so helpful for the public.
I know. And we do have to earn the trust of the public on big data. The care.data episode destroyed public trust big time. Mm-hmm. And they're very nervous about it going anywhere near industry. Of course, people who use our data, the CPRD, it's all anonymised. But you've got to be very careful about anonymisation. Mm-hmm. You've only got to give the date of birth and the postcode, and I've got you.
Yes.
So CPRD, when you get the data to do research on, and I've been doing research on it before I got involved with the MHRA. All I got was a funny number and the year of birth. That was all.
Fully safe.
Fully safe. Yes. But we do have to be careful about cyber attacks, even at the MHRA, particularly in CPRD, and we do take it very, very seriously.
There's been a strand through your career at St Thomas's with the enjoyment of regression analysis and then the appreciation of Stephen Evans' approaches that maybe led to work you've done, your De Testimonio, your Harveian oration. It is a masterpiece of discussion of where we are and where we might go. Is statistics an important part of your life?
Well, I would like to say yes, but I'm not a statistician. But I do appreciate statistics. I appreciate statisticians. Mm-hmm. I sometimes fight them as being too rigid. Mm-hmm. Their failure to appreciate, or failure of some of them to appreciate Bayesian techniques, for example.
You have written a short textbut, haven't you? On
yes, I have. Yes. Well, it's not on statistics. It's really on what my Harveian oration was about. Because I sort of sometimes irritated statisticians by criticising this use of the p-value.
Rightly so.
and as a distinguishing truth from falsehood.
Yes. So you've spent a lot of your life doing major national public health activities, but I know you do have still a research interest in Huntington's.
Yes.
Do you want to say a little bit about that? Yes,
well, when I was in Newcastle, I did a spell as the public orator. As a result of that, I got to know the man who was the Chancellor, who was Viscount Ridley. And I got to know him, and I got to know his son Matt, who's taken on the title and now sits in the House of Lords. I knew Matt had written a book called Genome, and it was a very good book in 23 chapters, 23 chromosomes, and there was, for each chapter, he told a story of one gene. On chromosome 4, chapter 4, it was about Huntington's disease and the way this woman called Nancy Wexler had discovered the Huntington's disease gene in Venezuela. Anyway, I was at a meeting at the RAND Corporation, and this little voice said, "I'm Nancy Wexler. I'm interested in Huntington's disease." And I thought, good God, what a fluke. Because reading the book, it seemed to me, of all the places in the world to do sort of genetic epidemiology, you wouldn't have thought of Venezuela. Anyway, Nancy Wexler said to me, "Do you think we could do clinical trials in Venezuela?" And I said, "I haven't a clue, I've never been to Venezuela." So she said, "Well, you better come, we're going next April, you join us." So I visited these poor people who lived in abject poverty on the edges of Lake Maracaibo. One particular little fishing village called Barranquitas. They live in hovels, earth floors, all in one room, huge families, no access to contraception. Now, in theory, doing clinical trials there, you just walk down the street and you can, find 100 patients with Huntington's disease. But it was while I was there was an attempted coup against Hugo Chavez, who was the president. And anyway, I returned, and Nancy was told that she shouldn't return by the State Department because it was too dangerous. Mm-hmm. So about a year later, I happened to bump into the Venezuelan ambassador in London. And I mentioned the fact that I'd recently been in Venezuela and been to Maracaibo, and explained the circumstances and how I wasn't likely to go back. And he said, "Well, that's a terrible shame. I think we could get you and Dr. Wexler back to the auspices of the British Embassy." And that's what happened. And so Nancy and I went back there half a dozen occasions. And I got involved in the Huntington's disease community in Britain as well, and I got involved in sort of advocacy for Huntington's disease, because one of the extraordinary things about Huntington's disease is that there's a terrible shame associated with it. There's a stigma. In America, there was sterilization. The Nazis exterminated people with Huntington's disease. The Swedes had compulsory sterilization. The Swedes, I know. And this mythology about Huntington's disease people being evil has sort of persisted. A friend I met through the Huntington's disease community, who is a journalist, TV and radio journalist called Charles Sabine, whose father has died from Huntington's disease, his brother's got it, and Charles has got the gene, has been very concerned about the whole absence of support for Huntington's disease, particularly from the Catholic Church in South America. And he organised an audience with the Pope. He brought over about 20 people with Huntington's disease.
From South
From
America?
South America. They don't even have a birth certificate, let alone passports. And he raised the money to bring them over. My admiration for what he did is absolutely unbounded. And the Pope was just wonderful with these families, and he hugged the people with Huntington's disease and blessed them, and I was introduced to him as well. Nancy Wexler was we were both invited there as people who are Huntington's disease advocates, and so we were both introduced to the Pope, who asked me to pray for him, which I thought, as I'm a lapsed Anglican. But he was a lovely man, absolutely lovely. Yeah.
Maybe I could ask you just some general questions.
Yep.
So what would you say to a young clinical pharmacologist about how they might progress with their career? What would your advice be?
Well, one of the great things about, some say it's great things, and one is makes it more difficult, is that you can cross-fertilise with different disciplines. So for pharmacology, genetics is going to be increasingly important. So to be a good clinical pharmacologist, you have to be more than a passingly good geneticist. So you've got to sort of choose the area and be prepared to learn from another discipline, as well as about the broad basis of clinical pharmacology. The other thing is that I would say, which they probably don't want to hear, is carry on doing general medicine, which I did all my career. I did general medicine, even when I was doing chairing nights. I used to spend weekends
Really?
going back, doing general medicine, doing the acute receptions, because I thought it was important just to make sure I knew what it was like, at the grassroots, what the real problems were. Because the reason why I say it is that a lot of what I've done is sort of multidisciplinary research. Mm-hmm. And you get the problems confronting you when you're doing real medicine. So that the important areas suddenly become relevant to you rather than just reading about them or dreaming them up. Mm-hmm. The other thing is what about collaborative research, because I did a lot of collaborative research in Newcastle with paediatricians. We did randomized controlled trials in paediatrics, with the dentists, with the dermatologists. So one's got to be prepared to look at other disciplines and get them engaged in the sort of tricks that clinical pharmacologists can pull.
Do you find time for a personal life outside of all that
Well,
work?
I'm not very good on holidays. I've been divorced for many years. I have 3 daughters and 8 grandchildren, all of whom I love dearly. And so it's my family that are the most important components of my life. Yeah.
Okay. And if you had to pick one part of your life, if that's possible, work life that you most enjoyed, where you felt that everything was going just as you wished it, if there was one?
Well, in retrospect, it was nice. I mean, at the time, sometimes, when we were being attacked by the Daily Mail and so on and so forth, it didn't feel very comfortable. But in retrospect, it was nice. Because we did, it wasn't me, it was we did make it happen.
Mm-hmm. Mike, thank you for giving us so much of your time.
Thank you very much for allowing me to drivel on.